let's move on to just one more immunotherapeutic drug, maybe has been lost in the shuffle, but maybe reemerging in combination with checkpoint inhibitors, and that is Ipilimumab, a CTLA-4 antibody. There's been some experience in lung cancer as single agent, which has not been impressive, at least with Tremelimumab, one of the CTLA-4 antibodies. But some perhaps more compelling data in combination with chemotherapy up front and in combination with immunotherapy up front. So Paul, you want to talk about this and how we make sense of these new agents and whether they will be a part of our approach?
Sure. I think the most mature data we have for the potential role for Ipilimumab is one study that was published by Tom Lynch and published in JCO now a few years ago. It randomized patients to getting carbotaxol as the backbone chemotherapy, and then Ipilimumab given either concurrent with the chemo or in a phased approach where they got a couple cycles of chemo, then got chemo and Ipi basically. And the thought was that you needed some kind of priming, right? You need an antigen release in order for the this immune checkpoint inhibitor to be effective. And that's what the trial bore out. It bore out that on analysis that the phased approach had significant improvements in terms of survival, overall survival, and progression-free survival. And so this is being carried forth now more formally in a randomized phase 3 trial also. So again, some early evidence, this is before PD-L1 inhibition really came to the fore, that CTLA-4 inhibition in conjunction with chemo in a phased approach might have efficacy. This was also apparent in squamous lung cancers in particular, more so actually if you took a look at the subset analysis. People, of course, are in the process of testing combination immune checkpoint inhibition. Nivolumab and Ipilimumab, Medi and Tremi were testing also. The results are still very early on. The number of patients who have been treated are fairly small. The results are promising, if a little bit difficult to interpret. The higher doses do seem to be more effective, but they're also a lot more toxic in terms of the autoimmune or immune-related adverse events. Too toxic, in fact, to move forward, which is why the doses have been trimmed down. It does look like that on balance, PD-L1 as a biomarker for Nivo-Ipi in particular seems to predict for better response also, but again, very small numbers. Now, this has not been seen for Medi-Tremi though, where patients who are biomarker negative seem to have just as good responses, also so yet even more confusion now in terms of the IHC test that's being performed. But the bottom line is that it's promising enough to be formally tested now in a larger fashion. And so we'll see exactly what ground we gain, although it's important to note that the advances we've seen so far in terms of the data or the promise is a lot less than we've seen in melanoma, which has the approval indication.
Yeah, it'll be interesting to see if these combination strategies move up front and supplant chemotherapy, and it will come down to a sequencing approach. Will combination followed by chemotherapy, or is it chemotherapy followed by immunotherapy? I've come out on the side that I think we're not there yet. I don't know when that will happen, where we'll move these drugs up front, but certainly the data that you went over is compelling, showing response rates, again, close to 40% in some of these combinations. So I think we're getting somewhere. How to sequence these drugs is going to be somewhat of a challenge, and we can talk about that at the end. Ed, your thoughts on the combination strategy here and whether it's going to be meaningful or not for patients?
I think, again, we're mirroring what's happening in the immunotherapy field with melanoma and renal cell, and they've certainly seen the benefits. You know, some of these drugs, not Ipi, but others are going to go to fixed doses as opposed to weight-based, and so that will change things a little bit. But you know, we've seen very interesting data in small cell and glioblastoma and bladder cancer and head and neck cancer and others. So there is a lot of excitement among the combinations. I do think down the road, whether that is a descaled chemo approach plus a checkpoint inhibitor up front, or a triplet that is one chemo and two non-chemos, could definitely
Possibilities
happen.
are infinite.
What I don't want to see is alphabet soup and everyone combining everything under the sun. I think the never smoker population made us put the brakes, since we're using checkpoint, we shouldn't just test everybody in these combos and it's just going to work in everyone. There's still prostate data out there that didn't show benefit as well. Right. So we want to be cautious and thoughtful, but I have no idea how we're preclinically going to assess these combinations if we can't do response or these other things. I have no idea how to do that.
It's getting confusing. I mean, even going to ASCO every year now and just the amount of information to keep up with, it is alpha. I mean, they're just throwing darts up on a board.
That's right.
And the combination strategies with perhaps not a lot of rationale of doing so, and trying to keep up with this is challenging, even as a guy who does nothing but lung cancer. So I think we've got a lot to learn, but I would encourage trials to really be rooted in science and some biological rationale, either clinical or molecular enrichment strategy, because I think it's just a free-for-all right now, what's happening. It's a total free-for-all. Okay, so let's